you don't really need it. We should actually show you, because there are laser beams that actually give you an even depth. So we'll show you that, but they also are getting the newer versions of the technology, which is great because it's just a computer upgrade, that you can also put markers on there and really be able to measure from those markers as well. Was when you first adopt the technology, that's the learning curve that I think we all need to have. One is that, is it a relative number? We don't have that relative number, but those of us who've used it for a long enough time, I can probably safely say that just with no data alone, just my own clinical acumen, that are roughly around 50s and, you know, going into the higher 50s, I feel that I have a chance to implement greater oxygenation. But the beauty is really is the change and really seeing the progression of, and then also seeing where it halts. Okay, and if it does halt. And then the other thing is that when we're talking about the chronicity of some of these wounds, we have that hyper response, right? So we have this really bright red fluorescing. And then also when we're in that remodeling phase, we still have a little bit of a greater red response. Now, what does that response look like 1 year from now after the remodeling phase has been completed? And does that now come back down to a 70%, you know? And we went from 50 to 90 to 70 back to normal. So what is that? So I think we have to, again, do that over time. But I was just talking to the company as well, utilizing that with all of the data that you guys have and integrating that. Does that come out with greater outcomes, and how can we do that with predictive values? And that will be, you know, artificial intelligence. And I think they're already starting, but I don't think I'm privy for that information quite yet. I really do think that it takes just repeated clinical acumen in order to really get that number. So as a member of the advisory board, we're actually doing our studies right now to actually give you a quantification of these numbers. So do we have that quite yet? No, we're collecting that data now. But again, just like we did with TCOM or SBP, right? We had a relative value that we were using. To be honest, they're relatively similar. Just again, from my own clinical knowledge and utilizing this, it's very similar to that. But could I tell you that we actually have those numbers quite yet? No, we're working on that. So, but yeah, right now we're starting to adopt this into evaluating to see how to do the surgical approach. Now, does that mean that it's mapping to really get an idea of whether this needs to be a TMA versus a BKA versus an AKA? I have not done that as of yet, because again, this does have a depth of penetration of about 3 millimeters. So do we really need more than that, you know, for true mapping? Probably, when you're looking up into the AKA. Yeah, if you're noticing that it's very cold or the patient is very cold, it is going to make a difference. So we do warm the patient a little bit to at least room temperature. Oh, I think it's actually, we're here because we're utilizing it ourselves with our interventionalists. And for the most part, you know, unfortunately, not every interventionalist, especially in our Las Vegas area, is really looking at angiosomes or where the wound is. You know, they may not be able to solve the problem from head to toe, but at least get me something to heal my wound. And so we are absolutely using it. And I think there is the great thing about the technology too is there's a reporting on it. So a lot of times I will send the report back to the surgeon or the interventionalist and say, this is what happened 1 week post, and they can use it right there, right after the intervention itself. But, you know, we're really probably more concerned about what happens a few days or 24 hours afterwards, and we can actually just send the report right away. So again, this is somewhat deceiving. You do have to have some clinical experience into understanding what do these colors really mean and how does that look like over time. When we were first using it, that was one of our biggest issues. Everything looked like, just like even SPY, right? We were using it in the outpatient. There was a great fluorescence, and then you had to look at the the egress and the ingress and the this and the that. Well, now you do have to have that same technology that you have to learn how to read it, and so having a chronic inflammatory wound stuck in the chronic inflammatory state, a lot of times is going to give you a much greater response, a bright red response. And does that really mean it's healing? No, it does not. We need to go from that bright red response down to somewhat normal, have a little bit of a plateau, and then probably start to see that increase right up again, to really ensure that there is, again, as you're saying, it's not a linear response. So, yeah, we're absolutely seeing that. Yeah, so some people are using it just to, image the feet, the plantar surface of the feet prior to anything, as to see if there are areas that could be susceptible to a wound, and if that is one, to have earlier intervention and or differing in shoe wear and things like that could prevent that wound. No, it does not get billed for preventative. Yeah, it in some ways, but I was telling them that I really strongly feel that reimbursement on this is really not the key. It's really our predictive values and how we're going to be starting to utilize this in order to show closure, and right now it's great, and we're using it all in our research and our clinical studies, and it really it validates what we're trying to do. So I hate to belittle reimbursement, but I do think that it needs to be looked at a little bit differently, in the sense that as a clinician, I am now held accountable to heal this patient quickly. And when that patient says, well, I want to eventually say, well, when is this wound going to heal, Dr. Wahab? And I can say, oh, there's a predictive value that I could possibly tell them that this is when this wound is going to heal. That's what I would like to do. We're not there quite yet. We need much more data, but I think we're getting there. I think we're really getting there. So right now we have insurance contracts with private insurances, and they want to have a conversation with me every month. And so absolutely are we using this as a explanation for the progression of that patient. And also I'm going to flip this to say that I'm hopeful that CMS will give us bonuses for good outcomes, but I think what they're also going to use this for is that there's bundled payments. And those bundled payments are going to say you have this much amount of money in this much amount of time. And my concern is that we as clinicians have to get there in that timeline. And we all know that that's sometimes extremely difficult, especially with our patients and their non-compliance and their other comorbid conditions. And so that, to me, I want to get ahead of that curve, and I want us to know what that number is, both for average healing times, and a really true monetary number that we can direct that with, so as clinicians.